For our speaker tonight, she obtained her degree in Doctor of Dental Medicine from the University of the East in Manila, and she is a licensed dentist both here in the Philippines and in California. She has completed various training programs to expand her knowledge in different fields both here and abroad. These include a postgraduate program in pediatric dentistry in Aichi Gakuin University, a course in functional occlusion in Tokyo, a postgraduate course in cosmetic dentistry in UCLA, and a program in biomimetic dentistry completing levels 1 and 2 in the NIHAD Institute in Beverly Hills, California. Our speaker is currently a visiting consultant in the Makati Medical Center, and she is also a consultant and lecturer in the Philippine Children's Medical Center. Without further ado, it is my honor to present to you our esteemed speaker for tonight, Dr. Mitsyrose Navales-Antolin.
Thank you very much for that wonderful introduction. Can you all hear me? Are we clear? Okay, I hope I will not have any technical difficulties at the moment. It is truly an honor and a privilege for me to be speaking before all of you. I would like to thank Philippine Pediatric Dental Society Incorporated for this invitation, most especially to Dr. Paula Baya. Thank you so much for the invitation. It's actually truly an honor for me to be able to be here. And you know, for many years, I've always wanted to give lectures to PPDSI, and I thank you, Dr. Paul, for giving me this opportunity right now. And I'd also like to acknowledge the presence of my colleagues in Biomimetic Dentistry, the society, and also my other study group, who's always been very supportive and who has inspired me to continue learning more about you know, how we can improve dentistry in our practices. So I just wanted to let you know that in this lecture, though I am not a KOL for any dental company at the moment, I do not receive any payment nor any free goods from any of the products mentioned on this lecture. So what I will be sharing to you are the products and the materials that I have been using in my practice. As you all know, I have been in practice for the last 21 years. Okay? I feel very old already. I have been actively practicing, and on the side, I teach pediatric dentistry at the Philippine Children's Medical Center. So I'd like to also acknowledge my students here, my present and my former students. And as you know that in the first few years of my practice, I have just limited myself to doing pediatric dentistry. But because of my love for our profession, it has encouraged me to learn more, you know, because, you know, as many of you know, medyo maarte po ako. So I'd like to create beautiful smiles for my patients. So having learned a lot of things in cosmetic dentistry, I was able to apply this to my pediatric patients. So as much as possible, I don't like pulling, you know, teeth. I want to preserve them. I want to be able to give children beautiful smiles. So these are some of the cases. Now for the past many years, you know, as you know that when I entered my practice, it was already the start, or maybe perhaps, you know, it's been a few years already that we've been doing a lot of adhesive dentistry. So I have been doing a lot of adhesive. I have done a lot of beautiful restorative cases in my pediatric patients through adhesive dentistry. So these are some of the few cases that I have, that even if sometimes, you know, when you feel that it's already bound to be extracted, but when you see the parent's face to me and requesting, Doctora, can you please not extract it? So I have tried to learn options on how I will be able to preserve this primary teeth. Okay. And even for adults, of course, I have done several aesthetic cases also for both veneers and composite bonding. And as you know, I am not your type of cosmetic dentist who forces the patients to do veneers and do crowns and do this extensive oral rehab. As much as possible, I want to preserve teeth. I don't like cutting enamel. So, you know, in the best as I can, I do as much as I can to really preserve the natural dentition. So what prompted me to learn and study about biomimetic dentistry? if you can look at this slide, this is my tooth, okay? It's actually quite frustrating that, okay, you have a beautiful endodontic treatment, a beautiful crown, and a post, and when I had this crown, I wasn't feeling anything. So, and then not realizing that there was an occlusion problem. So I'm a patient myself. So that's why this also prompted me to study about occlusion with the Dawson Academy, which I was supposed to finish this year, but unfortunately, due to the COVID situation, I wasn't able to fly to Florida to take my final course. So I just concentrated myself in learning about biomimetic dentistry. So I had this tooth extracted last year. So it was actually very frustrating because I didn't want to have this tooth pulled. I nurtured this infection for probably 5 years. It was, I had it, I had apicoectomy twice, hoping that it will regenerate. I didn't want to believe that there was fracture because, when we would probe it, it's 3 millimeter, there's no pocket, so that's why I said, why will this tooth be extracted? In fact, when I even went to Korea for a seminar, one of the speakers said to me that, oh, maybe you want to extract it and see what's in, and then we will replant it again. So until, I started, doing a follow-up x-ray on this tooth, and then I saw that there was already cracks. So it was very frustrating. It was very, very tough for me to accept that I was going to have a tooth that's being pulled, and now I will have to undergo, I will have to go implant with this. So with this, with Dr. Lily when she introduced me biomimetic dentistry, and then she told me, why don't you come with us and to take the course with Dr. Matt Dijad. So I started getting interested in biomimetic dentistry because of the fact that we are able to preserve teeth. We are very, very conservative. I've done crowns and onlays in the past, and I would still always prefer to do onlays over doing crown from my patient. But then, I've always had that doubt in myself if my restoration would last for my patient. So I took the course with Dr. Nijad and with some of my other colleagues. And then last February, because Dr. Ibuen is trying to spread the good news about biomimetic dentistry. So we had a conference in Boracay this April, and it was such a blessing that despite of that time that COVID was just about to start, we were able to push through with the lecture. And then we also had, 3 of the best speakers in biomimetic dentistry. We had Dr. Aliman, Dr. Gillespie, and Dr. Nijad to fly over, who they were very courageous to fly to the Philippines despite of the fact that there was already COVID-19 that was spreading around. Okay. So now that, because I had more time now, because of course, with the situation right now, I cannot fill up my schedule just how I used to do it. So I had a little bit more time, to take my time to do my restorative cases. So, as I do my cases, I started to really think on what is the real science behind it. So this prompted me to enroll with Dr. Aliman in the Center of Biomimetic Dentistry to take biomimetic mastership. So this September, I will be starting my course with them. And with this, they started sending me series of papers. So what I really like biomimetic is that there is science behind it. These authors, these doctors didn't just invent it. I mean, the steps and the protocols are backed up by research. Okay, so what is biomimetic dentistry? Biomimetic dentistry is the restorative dental science which restores damaged, decayed teeth with restoration, which conserve the pulp and restore function, aesthetics, and the mechanics of an intact tooth. Now, if you will dissect the word biomimetic, bio meaning lifelike, copy meaning you copy what the natural tooth really looks like. Now, the core principle in biomimetic dentistry emphasizes on the preservation of tooth structure and pulp vitality through restorative materials that mimic the properties of natural teeth. So what made me become really interested with this one is that, we are able to preserve tooth structure. Now, this is a very nice book that Pascal Mann has written, and he is about to publish his second book already on biomimetic dentistry. So in his foreword, he said that the biomimetic principle is that the idea that the intact tooth that is in its ideal use and shades, perhaps more importantly in its intracoronal anatomy and location in the arch, is the guide to reconstruction and determinant of success. The approach is basically conserve and biologically sound. The goal is to return all the prepared tissue to full function and the creation of hard tissue to bond that allows functional tissue to pass through the tooth, drawing the entire crown into a final aesthetic result. Meaning we have to copy what we have to mimic what we cut, we have to restore back the tooth into how God has created our teeth. Okay. So in conventional dentistry, let's just say you have this case that comes into your practice that has very deep caries restoration. Now, most of the time, you know, or in certain instances, we tend to expose the pulp. So when we have pulpal exposure, you know, the next step, of course, would be to do root canal treatment. And then how I was taught was any tooth that has undergone endodontic treatment was to go through crowns. So I mean, admittedly, I have done a lot of crowns on a lot of my patients, but I wish I learned biomimetic dentistry earlier in my practice, so at least I could have saved my patients' teeth from having crowns. Now, with the biomimetic, you do your very best not to expose the pulp, but I'm not saying that you're not supposed to do root canal treatment anymore, but at least try to be as conservative as you can and prevent the tooth from having a root canal treatment through the techniques that I will show you later. Now, biomimetics seeks to promote the science and merits of both conserving dentistry when compared to more traditional methods, and this concept can result into greater longevity of the natural dentition. So if you will look at the slide, you know, when you do an onlay, you only remove 35% of the tooth, whereas when you do a crown, you rip off the tooth from the enamel and you prepare the entire tooth. So what are the steps in biomimetic dentistry? So I will be enumerating each one: diagnosis of caries, isolation, caries removal, and diagnosis and treatment of structure compromises, immediate dentin sealing and resin coating, decoupling and fiber placement, and the placement of the final restoration and occlusal adjustment. So first is the diagnosis of caries. So this is oftentimes sometimes the most neglected part in our practice. Okay, a lot of us maybe have been in practice for over 10 years already. So you know, when a patient comes into your office and then you see, we always look at it clinically. A patient will come to you and tell you, "Doc, I need cleaning." So we just clean and then we dismiss the patient and that's it. So we rely a lot on our visual. Okay, so we do clinical examination, which check for the presence of cavity. But of course, if you look at this other photo, it's very obvious that there are cavities here. But sometimes what we do not, you know, we do not see what's really going on inside. So very oftentimes we would request for a panoramic x-ray, especially for patients who needs to undergo extensive dental treatment. But in my practice, if my patient will have to undergo extensive dental treatment, I would still do a full mouth x-ray, because sometimes we see things that are not, that cannot be visible with our panoramic x-ray. So to my students, you know, I always give emphasis on how important it is to take periapical x-ray. Now, this was a patient of mine who didn't come to me for maybe, she was my patient about 8 years ago, and then she didn't come back till like maybe till like last year. And then of course, you know, because it is routine in my practice to take bite wing x-ray, to take this, I take about 7 x-rays. Okay, so this is what I often do. And then I told the patient that you have several cavities. And then the patient was quite surprised, telling me, "What? I have a lot of cavities," when I actually, you know, go to my other dentist and I visit my dentist every 4 months. And how come you're telling me right now? Well, your x-rays are not inventing for you. So I would always tell my students that God did not give us a bionic eye to see through the patient's teeth. So it's very, very important that we take bite with x-rays, especially with children. Now, this was a case that I had last year. And I saw that, okay, when you look at it clinically, I mean, of course, to most of us, probably because, it's very sad that bite-wing x-ray is not routine part of our practices. Okay, but in my clinic, it is SOP for every patient who comes into my office that I will have to take bite-wing x-ray. So this is an 11-year-old patient. So when you look at it clinically, you would probably think, oh, she doesn't have a cavity. You'll probably dismiss this patient already and tell the patient, ma'am, your child doesn't have a cavity, very nice and clean teeth. But because, of course, we always take radiograph, so you can see through these x-rays that patient has several class 2 cavities wherein even the permanent teeth has already been affected. So with this, I mean, this is where I really felt how important bite-wing radiograph is and how important it is to fix primary teeth. So I had a patient earlier, and she told me that, doctor, can we just wait for the teeth to become painful since it's going to fall off anyways? And I told her, no, you cannot leave. Your child is only 7 years old. Okay, can you just imagine from 7 till 12 years old, the primary molar exfoliates at 12. So can you imagine for the next 5 years that they're going to be together? So what's going to happen to the permanent teeth? So I mean, even this one with this particular patient is already 11 years old. I probably wouldn't do anything here. But because I saw already that the permanent teeth has already been affected, then I would really need to do something about it. Now, this is another case. This is a case of this patient is about 14 years old. So she's been coming to us also, but for 2 years she didn't come to us. So of course we took our bite-wing x-rays. So again, we saw incipient class 2 cavity. So there was already starting problems. Now, if you are going to take bite-wing x-rays, I also recommend that you take 4. You cannot just take 2. Why? Because you need to see the caries between the canines and the premolars. So even with bite-wing x-ray, so how we do it in our practices, we take bite-wing x-ray after we do our prophylaxis. So with bite wings, you can also see calcular deposit. So can you just imagine, I mean, let's just say the patient doesn't want to pay for x-ray. Ilibre nyo na, because when you take bite-wing x-ray, 90% of the time, you will see things that you will not see with your naked eyes, and it will increase the productivity of your practices. So even with for example, if we have cases like this that we see calcular deposits, then we recommend the patients for deep scaling. So there are a lot of studies that advocates the use of bite-wing x-rays, and they say that visual examination and bite-wing radiographs used together remain the most pertinent caries detection tools in the clinical practice. So you can see here through with this figure that you can see that there's usually what we see already with our periapical x-rays are the ones that has already reached the dentine. So with bite-wing x-rays, you can actually see incipient caries. Thereby, you are helping the patient, prevent further progression of these cavities. So in a study by Akaya, he said that panoramic x-ray survey alone was not sufficient for the diagnosis of proximal caries for the entire dentition. The combination of panoramic plus bite-wing plus anterior periapical survey, just like what I showed earlier, exhibited a diagnostic accuracy for proximal caries that was comparable with full mouth series. So I take 4 bite wings plus 3 anterior periapical x-rays. So with that, you will be able to somehow see what is really going on underneath those very clean looking teeth. Now, of course, some of you might think that with biomimetic dentistry, you don't need root canal anymore. No, I do not agree with that one. If the patient needs to undergo root canal, then they have to undergo root canal treatment. So that's why it's very important that we take vitality tests. Okay, so we have the cold test and then the heat test, and then we percuss. Now, if the patient is asymptomatic, you can go ahead and tell the patient, okay, we have this technique, we can just try first to see how we can preserve it. But if whatever conservative method that we have tried will not work, then you will still have to undergo root canal treatment. Now, the second one is isolation. Now, this is a very, very important tool in our practice. Now, I have blessed to be, because I have been practicing pediatric dentistry for the last 21 years. So all my cases that I do with pediatric dentistry, most especially when I'm doing pulp treatment, is I use rubber dam. Regardless of the patient is uncooperative or cooperative, if I will do pulpotomy or pulpectomy, I have to use rubber dam. The success of my treatment will mainly depend on how I isolate the tooth very well. So the two of the most, the ones that I use right now is Sanctuary and Nectone. Now, oftentimes we have problems with placement of rubber dam. Mainly, I see it with some of my students. It's because, you know, the rubber dam clamp is not very good, or sometimes with how we create the holes, the holes in our rubber dam. So, I mean, if you look at the YouTube, if you look at YouTube right now, there are a lot of how, you know, like videos on how to put rubber dam. And one of the things that I appreciate with biomimetic dentistry is that it taught, you know, I'm already good in putting rubber dam, but it made me better right now. So I would probably say, you know, when I used to do my my restorative cases, maybe I would probably say, I would maybe about only 20% of my cases that we use on the rubber dam. But right now, I'd say it's about 100% of my cases for restorative procedures that we do on the rubber dam isolation. Now, for children, I never do sedation cases without rubber dam. So what I do is I do multiple, I put rubber dam on multiple teeth. So you can actually extend, even for adult teeth, you know, you can actually extend it up to the second premolar and the adjacent tooth. So what is good with using rubber dam is that you can also do multiple caries. And believe me, my life has never been this. It has been so much easier right now to do restorative cases because I use rubber dam. And not only that, okay, now that we have COVID, one of the requirements that they have against that to protect ourselves is to use rubber dam. So in the interim, on the control guidance of the CDC, they have recommended to use rubber dam isolation. So honestly, I feel very secure with my treatment right now because, like what I said, 100% of my restorative cases, even if I do AGP, that we use rubber dam. Oops. Okay, now let's just say I'm really, you know, I know, you know, I have some of my colleagues that no matter how much I convince them to use rubber dam, they still have a difficult, you know, time with it. Okay, so what is actually also good is, you know, with the use of isolation systems such as this Isolite, Dry Shield, and Mr. Thirsty. Okay, I've always wanted to use Isolite system. Maybe for the last 3 years, you know, with my dentist friends in the US telling me that Isolite is the best. But unfortunately, because it's too expensive and plus I'm good in using rubber dam, so I said, okay, then why buy the Isolite? But if you really, really cannot use, I mean, these are some of the things that you can actually use, because one of the keys to a very successful restoration is how you isolate your teeth. Okay, so what I have right now in my practice is Mr. Thirsty. So this one also I use with oral prophylaxis, and sometimes, let's say if I'm just doing very small sealant, I use the Mr. Thirsty as well. Okay. Number 3 is caries removal. This is another step that somehow that we think na, you know, doing a tactile, using your excavator, that you have already removed everything, but actually not. Now, this is a tooth which I have sectioned very recently in preparation for this lecture, and I took a radiograph. So I was very happy to have this tooth with me, and then I said, okay, so this is a very good example of how I can show you, you know, that sometimes, you know, when we take a radiograph, we would automatically think that in this radiograph that this tooth is already indicated for root canal treatment. But when you cross-section the tooth, that there is somehow a little bit of dentine that is left of the tooth. Now, in the study of Fusayama, he studied about the inner and carious dentine. So you ask yourself, so which part of the dentine, carious dentine, should be removed? Now, the outer carious dentine is the highly infected and acidic and demineralized. And inner carious dentine, partially demineralized, slightly infected, but the collagen fibrils remain in their natural structure around the intact dentinal tubules. Now, how we were taught in dental school is that we use our explorer. Okay, but sometimes we don't realize that, you know, using the explorer can also damage the tooth. So what the biomimetic dentist has recommended is the use of caries detector. And the use of this is Diagnodent by Cavo, but this is a very expensive tool. Now, caries detector, I have been using caries detector in my practice again for the last 21 years. Why? Because since I was trained in Japan, my teachers and my professors were already using caries detector. So caries detector has already been a part of my practice. Now, what I use is the one of Carrere, but unfortunately, this is not available in the Philippines. So what they have is a Snoop by Pulpdent. I think Orden sells this. And then the Sable Seek by Ultradent. So the application of the caries detector dyes facilitate diagnosis of caries dentine was initially introduced by Takao Fusayama in 1979. So since 1979, they have been using caries detector. For myself, I have been using caries detector since 1998. So that's when I opened my practice in 1998. So since then, the caries detector has always been a part of my practice. So what is our goal in caries removal? To determine our caries removal endpoint, create a peripheral sealed zone, avoidance of pulpal exposure, create a highly bondable surface for long-term restoration. Okay, so how do you go about it? Now, this is a study of my mentor, Dr. David Aleman, that we're in. This is a paper that you can actually download on the internet on a systematic approach to deep caries removal. Oops, sorry. Okay, sorry. I have to go back. Okay. All right, okay. So we're here in figure 4, the deep caries lesion has two parts, the outer and the inner caries dentine. The inner caries dentine has 3 parts, the turbid layer, transparent zone, and the transparatal zone. So what we do with the caries removal endpoints is we only remove the outer caries dentine. Okay, and then by using visual and tactile methods for deep caries removal, the pulp is often exposed because of the transparent zone, and the sub-transparent zone, normal deep dentine and reparative dentine are all softer than the superficial and intermediate dentine. So you have to remove only the outer caries dentine. Now, since the late 1960s, the goal of removing only the outer caries and saving the inner caries for mineralization has been recognized. So in a lot of papers, they say that you only remove the outer caries, and then you can actually leave the inner caries for remineralization. Now, how do we... Sorry, I doesn't want to go next. Okay, so we have to identify our caries removal endpoint. So when do we stop? Now, in the paper of Dr. Aleman and Dr. Pascal Mann, they recommended that you remove only 5 to 6 millimeter from the occlusal surface. Now, it's very, very important, again, that you will have to use your caries detecting dye for you to be able to identify the areas that you have to remove. So you can use for an occlusal caries, you have to measure it, at least do not go beyond 5 to 6 millimeter to prevent yourself from exposing the pulp. Okay. Now, from the DEJ, at least less than 3 millimeters. So let's say if you have a class 2 cavity, for instance, this particular case that I did about 2 weeks ago, I left some caries dentine on this area. Now, the concept of peripheral seal zone is that the enamel, DEJ, and superficial dentine constitute caries-free area of a highly bondable restoration. Meaning to say that you have to create a peripheral seal zone wherein your dental material will bond into an area where there is no more caries. case. So here's a good illustration of what I did. So this is a case that I did also very recently, that if you can see here, I removed all caries around the area. So this is my peripheral seal zone. So when you use a caries detecting dye, you have to make sure that you remove all the caries around here. Now, if let's say that you are already more than 5 millimeter, then it's okay to stop. So you can leave this area, because when you seal this area very well, if you seal this area, the peripheral seal zone very well, then there will be no micro leakage. Okay, so this area can remineralize on its own later on. So in the AAPD guidelines, pulp therapy for primary and immature permanent teeth indicates that there is no conclusive evidence that it is necessary to enter the tooth to remove the residual caries. So in older times, remember that, you know, when I was starting in practice, if I remember it right, that some of them, they say that you remove the cavities and then put on a temporary and then make the patient go back. But right now, it's not necessary to do that anymore. As long as the tooth remains sealed from bacterial contamination, the prognosis is good for caries to arrest and reparative dentin to form to protect the pulp. Now, this is another study by Ruth and Shine, that the long-term survival of indirect pulp treatment performed in primary and permanent teeth with clinically diagnosed deep caries lesion, they say that the survival rate for primary teeth was 96% in a 3-year survival analysis, okay, and 93% for the permanent teeth. So there are a lot of studies that support this technique. Now, this is a case that came to me last week. Okay. Now, this particular case, the patient, you know, I was actually quite surprised, because when my secretary said, I said, what am I going to do if it's just for cleaning? Then, because when I was going through the chart of the patient, I said, oh, she doesn't have any cavities, and the patient is already 6 years old. But my secretary said, oh, the mom said that the tooth cracked. Okay, then I was thinking, where could it have cracked? And then the patient came to me. When I looked at it clinically, it was just this small. I mean, if I didn't take a radiograph with this one, I probably would do this without, okay, sorry, let me go back. Okay. So I probably would do this case without putting local anesthesia and just go ahead. But then, of course, you know, it's routine in our practice to take preoperative x-rays so that we can see what's really going on inside. And I saw that the cavity is very, very close in proximating. It is already proximating the pulp. So with this particular case, you probably would just tell the mom, oh, we need to do pulpotomy already. But then when I interviewed the patient's mother, and then when I asked, is there any persistent pain? No. Can the patient sleep? Yes. Is there... Is your child crying already because of pain? No. Okay, from a scale of 1 to 10, what is the, oh, she's not complaining of anything, I just saw it crack. So that means that the tooth is still, you know, the tooth is still vital, and then there is a possibility of no pulpal exposure yet. So with this particular case, what I did was I just did a restoration. I did biomimetic dentistry for this case. But for this one, it is very, very important, again, that you have to use your caries detecting dye. So before I was able to reach, to be able to create my peripheral seal zone, I probably used my caries detecting dye 10 times, okay? I didn't have the liberty of taking too much photos because the patient started crying already. And then I just had to make sure that I was doing this case very fast. But with this one, I was able to remove all the caries here. So no matter how good we are with excavation, it's still very, very important that you use your caries detecting dye. Okay. Now, in my practice, these are the tools that I have. Okay. For every patient, I have one burr kit. So in my burr kit, what does my burr kit constitute? I have my 330 burr, 557 burr, my straight diamond burr, different sizes of my round diamond burrs, and then I have my number, my 1/4, number 2, number 4. Sorry, I go back again, number 5 burrs. So I have a lot of burrs, especially now that it's COVID. You know how we were in dental school, right? That we have this burr kit wherein we just pick up all the burrs and then that's what we use. But of course, right now with, especially now you with COVID, you cannot expose your burrs, to use for your patients. So for me, for many years, we have always had one burr kit for every patient. So if, let's say, if my secretary, my assistant sends me, brings out to me one burr kit and I need another burr from another burr kit, I will tell then when we open it up and then we autoclave it as one. Okay, so, and then also electric handpiece. I love my electric handpiece. One of the things that I love about it is that you're able to control the speed of your, the torque of your handpiece. So with this one, you can use it in high speed and low speed. So what the burrs that I use for my practice, I invest a lot on burrs. I use Brasler most, and then we have also Shofu and SS White. But what I basically use it, 90% of my burrs are actually from Brasler, which again, I'm so sorry, it's not locally available in the Philippines. Okay, so when I remove dental caries, I use carbide burrs. Now, there are studies that indicates that tungsten carbide burr or carbon steel burrs in low-speed contra-angle handpiece are the most efficient method to excavate carious lesions in terms of time and are therefore still the most widely used in caries excavation method. So I use slow-speed carbide burrs, especially for children. Okay, with children, what I like about this, it's not very, the patient doesn't feel much sensitivity. So even if, let's just say, I have very small carious lesion, it's very small class 2, I just open my class 2 with my 330 burr, and then I use my carbide, no anesthesia, and then the patient doesn't feel anything. Now, with the biomimetic principles, they recommend that you use a magnification of 5 times range when you perform biomimetic restoration. Now, at this point, I am at 3.0. Okay, and one of the things that my mentor has told me is that I have to increase it to 5.0. So I'm still about to order my 5.0. Right now, I am at 3.0. I'm seeing things clearly, but I really feel that I need to see things more. So I'm about to increase it. And some biomimetic practitioners, they also, like Dr. Lilian Ebuen, they use microscope. But for children, it's gonna be quite hard to use a microscope because they keep moving around. So I would, I would rather use a magnification of 5.0. Now, air abrasion. This is another important tool when you're doing biomimetic dentistry, but it has also been a very good tool for dealing for use in restorative dentistry for children. Now, what I have in my practice is this crystal mark, which sometimes I use even before sealant or for my preventive resin restoration. So when I remove dental caries, the thing that I use on the last step is my use of air abrasion. Now, air abrasion for preparation removes the tooth structure using aluminum oxide. Now, into compressed air or bottled carbon dioxide or nitrogen gas. The abrasive particles strike the tooth with high velocity and remove small amounts of tooth structure. Now, what we have locally in the Philippines is AquaCare. That is, I think, being sold by the dental company also of Dr. Lilian Ebuen. So this is actually a very good tool, especially for doing a pediatric dentistry, that air abrasion is actually good for doing PRR and some sealants. Next is the diagnosis and treatment of structural compromises. I'm not gonna give too much emphasis on this one because with pediatric dentistry, we don't really have much cracks, no. But for, let's say, if you have a very, very large restoration for, let's say, for a tooth for a number 6 that has been badly carious, it's very important also that you have to remove the cracks and identify the cracks, because this is where the bacteria penetrates into. So for example, for this particular case, I had to create the class 2 restoration with this one, because if you look at it on my bite wing x-ray, you cannot really see anything much. But when I removed it, there was already carious lesion on the proximal. Now, we also need to identify how much tooth structure is left. Now sometimes if let's say that your cusp tip is less than 2 millimeter, you might want to consider doing an onlay for this case. But this is a more advanced learning on biomimetic dentistry, which actually you can download on the internet on the different steps and protocols in biomimetic dentistry procedures. Now, number 5 is immediate dentin sealing. Okay. This is another, very crucial step in biomimetic dentistry. Now, there are so many bonding systems that are readily available in the market. So we have our etch rinse system and our self-etch system. Now, the 4th generation, wherein you do the acid prime and then there's an adhesive, and then the acid prime and adhesive for the 5th generation. So most of the time, this is what we actually use. I've actually done used the 5th generation for quite some time in my practice, but right now what I use in my clinic is the self-etching system, wherein you have a combination of, which is the 6th generation, wherein the acid and the primer has been combined, and then you apply the adhesive separately. And also now we have the 7th generation, wherein they combined everything. Now, for the assurance of better restoration, it is important to examine the strength and the structure of the teeth. When considering the strength of the complex of the tooth substances, the strength of the tooth structures can be the measure of properties of the restored teeth. Now, what do I mean by this? Okay, it is important. Remember, biomimetic dentistry is about copying the natural dentition. Okay, so we have to understand that what is the cohesive strength of the enamel. So an enamel has about 30 megapascal in cohesive strength. Now, what bonds the enamel to the dentine is the DEJ, which has 50 megapascal in adhesive strength. And the dentine has 60 megapascal cohesive strength. Now, this is another study by Pascal Mann, and this paper is actually also downloadable in the internet, wherein he said that a tooth is a veneer of an enamel biologically adhered to the dentino-enamel junction. So because we are trying to mimic, okay, the natural dentition, we have to be able to have a bond that will mimic the DEJ. So the goal in bonding in biomimetic dentistry is to create a strong bond to dentin which mimics the DEJ or the dentino-enamel complex. Now, with this, we have to optimize the condition of the substrate, which is your dentin, and allow time for the polymerization reaction to create the highest bond strength, minimize the stress on the developing bond for about 5 minutes. So you have to wait for the bond to mature. Now, for your indirect restorations, what the biomimetic doctors have recommended is to do immediate dentin sealing. Now, what is immediate dentin sealing? This is the application of dentin budding agent to freshly cut dentin when it is exposed during tooth preparation for indirect restoration prior to the impression. Okay, so you have to seal the dentin first. You have to secure that bond. Remember what I told you. You have to create a bond that is somehow similar to the DEJ. So the advantages of immediate dentin sealing, this is when you already try to prepare your restoration. Freshly cut dentin that is ideal substrate for the dentin bonding. Pre-curing of the dentin bonding agent leads to improved bond strength. Immediate dentin sealing allows stress-free dentin bond development, and immediate dentistry protects the dentin against bacterial leakage and sensitivity during provisionalization. So in the paper of Dr. Pascal Mann, which is again also downloadable, so if you'd like to understand more and more about immediate dentin sealing, you can look up his paper. And then we can do resin coating after we do your bonding. wherein a flowable resin or lower viscosity restorative material with a modulus of elasticity of about 12 to create a more secure bond. So after bonding the dentine, I place about 0.5 millimeter of flowable composite. So what I use is Clearfield Majesty Flow, and then the other flowable composite that they also recommend is PermaFlow. Now, if you want to level up your practice in dentistry and be a biomimetic practitioner, it is important that we use the gold standard in bonding system. But then, unfortunately, these two bonding systems are not locally available. So what they recommend is the use of OptiBond FL and Clearfield SE Protect. What I use is Clearfield SE Protect. Okay, this is what I use in my practice. So the microtensile bond strength of a 25 megapascal to 35 megapascal on enamel and 42 megapascal on the dentine on flat surfaces. So there are studies that shows that the closest to the reason why they have done this as their gold standard is because the megapascal of OptiBond FL is about 50, which is very, very close to the dentine, and Clearfield SE of about 45. Okay. Now, if we don't have Clearfield SE bond in the Philippines, what Dr. Aleman has recommended when we had our conference was the PQ bonding system of UltraDent. Now, again, but then, of course, if you don't have that, I would really like to emphasize that you are able to remove your caries dentine very well, just like what I have said in the initial steps. Now, the bond strength of etching primers to enamel and dentine of primary teeth in a study says that Clearfield SE bond achieved the most adequate bond strength to dentine of a primary teeth. This is a study by Agostini indicating that Clearfield SE bond has a very good bond strength to primary teeth. So if you have friends in the US or in Singapore and other countries, I mean, you can probably ask them to buy your Clearfield SE bond. Now, the success of your restoration highly depends on your bond. That's why in biomimetic dentistry, we always say, stay bonded. Number 6 is decoupling and the fiber placement. Okay, to minimize the destructive effects on contraction force exerted by the polymerizing composite is called decoupling, with time accomplished by establishing the bond to dentine separately from the bond to enamel and then allowing sufficient time for the dentine to bond to achieve at least 90% polymerization in indirect composite cases of about 5 minutes. And if you want to 100% polymerization of about 30 minutes. So decoupling meaning you have to wait at least 5 minutes for your bond to mature. Okay. So the bond strength increases with time due to the polymerization reaction. So it's important that we minimize stress on the dentine bond for about 5 minutes to achieve a good bond. Meaning to say that you have to at least give yourself 5 minutes that you initially bond to the dentine, with the use of your bonding agent, with the use of your resin coating, and at the same time also you can put your fibers after that. So for large restoration, fiber inserts on pulpal floor and eggshell walls to minimize the stress on the developing bond strength of the hybrid layer. So with this one, this is a case that I had wherein I used EverX for this tooth and then this other one, Rebond. Okay, so what it does, it minimizes the stress on the developing bond strength of the hybrid layer. So it minimizes the stress on your restoration. So there are a lot of studies right now indicating that the use of EverX is actually very good for deep caries lesion. Number 7 is the placement of final restoration. So it's regardless of whether you do direct or indirect, what is important is you are able to create that dentine bond. Okay, the success of your restoration will mainly depend on your bond. Okay, so with this case, for this particular case, I did it. This one is a direct case, and then for very large, especially with those with cuspal involvement, I prefer to do indirect restoration. Now, in the study of Simon de Liperi, he used we all know about this already. I mean, this has been taught to us several times that we need to do, we have to use layering technique and of using the oblique successive cusp placement, okay? And then, of course, lastly, we have your occlusal adjustment. Okay, I'd like to be able to have more time to show you my cases and step by step. So this is one case that came to me about a few months back. And now with this patient, the chief complaint basically of this patient was my child has caries on her teeth. So if you will look at this clinically, you probably would think that this tooth would just maybe need a sealant, okay? And then perhaps, do an extraction for this tooth because this patient is already around 12 years old. So when I took the radiograph, I wasn't concerned anymore with her chief complaint because I already panicked when I saw the x-ray on this tooth. So you can actually see here already that there is a radiolucent area on the occlusal, on this, underneath the enamel. So when I opened the tooth initially, I just used a Fisher burr thinking that it is going to be, just a very small restoration. So as I removed the cavities, I saw that it is somehow getting a little bit deeper. So, and then after which I used a caries detecting dye. Okay. So as I use my caries detecting dye, of course, I would still need to remove more of the cavities and I was getting deeper and deeper. So what alarmed me most is that, okay, this is a young permanent teeth. Of course, when you have a young permanent teeth, the cusp, the pulp horn is very, very high. So you have to be very careful. So with the technique that was taught to me in biomimetic is that you have to identify your caries removal endpoints, meaning you have to know where you will end your caries removal. So when I measured this one, I said, oh my goodness, I'm already 5 millimeters, so I have to stop. So I removed a little bit more, and then I created a peripheral seal zone. So as I use my caries detecting dye, I'm able to identify the caries are in around the outer dentine. So you have to make sure that this is very, very clean. Okay. So I stopped already, and then I use my air abrasion to be able, to create those microporosities for better bonding. Now, if you don't have an air abrasion, it's okay. You can just use your low speed carbide burr, or you can also use your diamond burrs at a very, slow speed. Okay. And then we bevel the enamel for increase, because with this one, I'm going to use my self-etched primer and not the fourth generation. So I need to bevel the enamel to be able to create more bonding to the tooth structure. And then prime for about 20 seconds. Okay, you prime it very well, and then you air dry for 10 seconds. Now the placement of bonding agents of about 5 to 10 seconds. And then when you remove the bonding agent, do not air dry, because air drying will thin out the oxygen inhibition layer to go down into the hybrid layers. So this will somehow affect, diba how we were used to in dental practice is that we air dry it. Okay, but now they recommend the non-air drying by using you just brush off the excess bond so that you will not thin it out too much. And then you cure for 20 seconds. And then you apply your resin coating of about 0.5 millimeters. Now for this particular case, because it was somehow deep, okay, I decided to use my EverX fiber for this one to be able to create a better bond of my restoration. So you place your hybrid layer, which is my Clearfill APX, and then I place my fiber on top of it. And then because remember the 5 minutes, okay, you have to wait for 5 minutes, and then 5 minutes has already lapsed, so now I am able to etch the enamel. Because when you're using the two-step, okay, you are not supposed to etch the dentine. So that's why I have to make sure that I secure first my bonding in the dentine before I can use an etchant on my enamel. Okay. And then you place your bond, and then you can do your incremental placement of composite. You have to remember that with what I've said earlier, that the enamel and the dentine has, you know, different bond strength. That's why you have to make sure that you separate their bonding. You have to make sure that you bond the dentine first before you place your final restoration. It is not recommended that you do bulk fill. But of course, sometimes for children wherein you're rushing, you know, when you're doing primary teeth, it's okay to bulk fill. But then for permanent teeth, if you want your restorations to last longer, you have to follow these steps. Now, then this is the final restoration before and after. And if you will look at it radiographically, you can actually see here that there is a little bit of radiolucent area, which is the inner caries and in which I have left. But if you can see on the occlusal surface on the enamel area, I have bonded it very well. So I am not worried that this tooth will have secondary caries later on, because I am very secure of the bond that I have created on my peripheral seal zone area. And then I extracted the primary teeth here. Now, this is the case that I have showed you earlier, okay, wherein you have a very deep caries lesion. So with this one, I created my peripheral seal zone and I left this part of my inner carious dentine. And then I placed my final restoration using my bonding agent, my resin coating, and then my hybrid layer, and then my final restoration. Now, I couldn't show you the steps because the patient started crying already. So I had to make sure and rush into finishing the case. Now, this is a class 2 restoration. For class 2 restoration, the matrix that I use for children is usually T-band. T-band is a very easy to use. I mean, a lot of the pediatric dentists already are using this one. But for some of the general dentists who are not familiar with T-band and still make use of Toffelmar, this is a very good material that you can use for your class 2 restoration for primary teeth. Okay? So when you this is before and then after. So when you look at my radiograph, okay, so you can see that this is my preoperative radiograph. It's very close to the pulp. And then this is my final restoration. So I am able to create a very secure bond. This x-ray is not very clear because the patient was already very anxious. So you can see here that it is already proximating that my restoration is very, very close to the pulp. Okay. Now, this is a case that I have done many, many years ago. So I'd like to showcase to you the anterior cases that I have done. Okay, so I have a few more minutes to go. I'm running out of time, but I hope I'll be able to show you some of my cases without really rushing. So with this one, okay, being a cosmetic dentist, I don't like to put stainless steel crown, but for some of the pediatric dentists, it's okay. You can put your stainless steel crown, but for myself, I have not put a stainless steel crown in my practice. So this is a patient that came to me with a fistula already. I like what I said, I like to save teeth. I don't like extracting teeth. So with this one, I did a pulpectomy, and then after 1 month after I have restored the patient's teeth, you can see that there's no more fistula. The teeth is the gums look very healthy. The patient is very happy. Now, this is a case, an emergency case that I did very recently, maybe last July, okay? So the patient wasn't eating anymore. So in as much as I would not want to do HGP in our practices, some patients need help, okay? So this is a case that I did. So if you can see here that there's hardly any tooth structure already. Most of you would probably tell me, why did you still save it? Why don't you just extract it? I don't like pulling teeth. As long as there's tooth structure left of the tooth, I will still save it. Okay. So when you look at it radiographically, I did pulpectomy for tooth number 5-1 and 6-1, I did pulpotomy. So you can see from my radiograph how nicely bonded. So with this particular case, I used the principles of biomimetic dentistry. But for the past years, I haven't past years that I didn't know of the steps, I was just using, a regular bonding system. But apparently, most of my cases have lasted my patient for a very long time. Now, one of the keys to, when you're doing all these cases, I highly recommend that you use rubber dam. I know some of you, natatanggal, it's so hard, it is not an excuse. Yes, you can put your rubber dam. I don't do my SOCs anymore without using rubber dam. The case that I showed you earlier, I did rubber dam on that one. I just didn't have the time to take photographs because the patient was sedated, so I couldn't take to rubber dam. So this is an example of sometimes, let's say if you cannot clamp through the molars, you can hold it, okay? Because what the rubber dam does also, it seals the area of the gums from bacteria. From fluid. Okay, so with this one, you can also use your dental floss. And then with this particular case, I did pulpectomy. Okay. So this was a case I did in 2017, I think. Okay, so this time I still didn't know much about biomimetic dentistry. But if you will look at this photo, you can see I was already using my caries detecting dye. So from this, even way beforehand, I was already using caries detecting dye. That's why my restorations last me for a very long time. So with this particular case, what I do sometimes to be able to bond my restoration well is I, cauterize a little bit of the gums. But you have to remember, there has to be at least 3 millimeters, okay, from the tip of the bone inside. Okay, so I do a little bit of like a baby crown lengthening on this case. So when I removed it, okay, so when you look at this photo, it seems like, oh, this is not very, the cavity doesn't look very deep, but as I remove the cavities, it's already been broken down. Now, if you will look at my radiograph again, you can see how much I have sealed my restoration. And this patient lasted, okay? This case, the tooth exfoliated at 7 years old. So I did this when the patient was about 2.5 years old. Now, this is another case. So what I said, I extend a little bit. But now, knowing that I have a very, very strong bonding system, I have a bonding system that has about almost 50 megapascal. Okay, I know that I am more confident in not extracting the teeth because I know that I have a very good seal of my restoration. Now, so you can see here, okay, what I do sometimes is I, make it a little bit smaller than the rest of the tooth so that, when the patient plays, when they hit it, at least it's not going to, fall off very easily. So now this is another case which I was very happy because, this little boy, okay, when I did his teeth, he was only 1 year and 9 months, I think, okay. So what I did this case because the mom didn't want me to pull the tooth. So I did pulpectomy for this. I do not have a radiograph of this one because this was taken in 20. This was done in 2012. I didn't have my digital X-ray yet. I had periapical X-ray. I couldn't retrieve the patient's records anymore. But I remember this patient that when he was 7 years old already, his permanent teeth was already there, and my bonding and my strip of crowns was still there. It didn't exfoliate, so it was still there. So it lasted the patient for more than 5 years. Okay, I am confident with what I do for my patient because number one, I isolate it very well. I remove the cariesation very well. I always do my cases under rubber dam isolation. Okay, now this is a case that I will just try to run through. I mean, I wish I get invited again so that I can give you some of my aesthetic cases, but this is, badly, this is a trauma case. So this is another topic that I wish someday that I'll be able to share with you, but I'll just run down some of my cases. So with this one, the patient fell and hit her anterior teeth. No, so with this, I did this is what you call the starburst bevel. And then with this one, I wasn't a biomimetic dental practitioner yet. So I just use a one step. And then when you're doing your restoration, you have to mimic the adjacent also. So if you can see here, I have flowable composites that are, white in color that can, if let's say if the patient has a little bit of fluorosis, I copy that too. Okay. So this is before and then this is after. Okay. So this is a young permanent teeth. So you create your mamelons as well. Now this was another case that came to me, and then again, we copy what the natural tooth, the adjacent tooth should look like. So I created that mamelons also. You can see that this is a very good restoration here. Now this was a case that I showed you earlier. So with this one, we copy also the mamelons and how the adjacent teeth looks like. So with this one, I've created that as well. So you can hardly see the demarcation line between the restoration. So you have to learn how to use your composite, your dentin shade, your tints, your enamel shades. So you have to be able to learn how to do your layering technique properly. There, thank you. Okay, I hope I am right with time. I'm already 10 minutes past the 1 hour time given to me. So I just want to give you some of my take-home notes, okay? Number one, do proper diagnosis. Take bite-wing radiographs and do thermal tests. So it's not, okay, with biomimetic dentistry, it doesn't mean that when you do biomimetic, you will not do root canal treatment. That is not true, okay? When you do biomimetic dentistry, it's important that you diagnose the tooth very well. Now, if there's no more response to cold test, that means the tooth is dead, then you have to do root canal treatment. Now, if the patient has persistent pain and the pain is already lingering, patient cannot sleep, then you have to do root canal treatment. But to restore it, you can make use of the biomimetic principles wherein you do your IDS and you do your indirect restoration. Number two, isolate well. Please, please, please practice to use rubber dam. I tell my associates, rubber dam is life, okay? I don't want to do my restorations anymore without the use of rubber dam, especially now we have COVID, the rubber dam. I'm not saying it's 100% protection, but somehow it also protects us from the possibility of having contamination from our patients. Now, identify your caries removal endpoints and create a peripheral sealed zone. Please buy your caries detecting dye. It is not expensive. Caries detecting dye probably cost around 1,000 pesos. I don't know how much it costs you, but it costs me around $25 in the US for my caries detecting dye. So if you don't have caries detecting dye in your practices, please buy cavity detector. That is another important tool in our practices, regardless of whether you do biomimetic dentistry or not, okay? Use a very good bonding system, okay? As much as possible, if we can go for the gold standard, let's go for the gold standard. Of course, with biomimetic dentistry, we're trying to improve the level of our practice, okay? Wait 5 minutes for your bonding to mature to dentin and do immediate dentin sealing for your indirect restoration. As much as possible, please do not do bulk fill. A lot of studies right now are showing that bulk fill is not good. Okay, when you do your restoration, take time and mimic the natural dentition. Right now, when I'm doing my biomimetic dentistry, when I'm doing my restoration, one tooth would probably take me about an hour and a half to 2 hours because I really take time in carving. I try to do my best to make my restoration as beautiful as how God has created our teeth. Okay, and again, and lastly, as long as there is hope for the tooth. Okay, if you feel, in my practice, I always pray and I ask for God's conviction as to whether to extract it or not. Okay, please do not extract teeth. Okay, I don't like it. Breaks my heart when I see cases of all teeth, primary teeth being extracted. I mean, with all due respect to those who does it, it's okay if that is your conviction. But for myself, okay, my students know this. I don't like extracting teeth. I always take preoperative radiographs. Sometimes if you see badly carious teeth that is already on the level of the gums, if you take your periapical x-ray, you can see some of those cases doesn't even have pulpal exposure. So the teeth is very, very much alive. So why will you extract it? I've done stainless steel crowns that's already almost flattened out, but I still do as much as possible to save it. Especially now learning about biomimetic dentistry, there's so much hope for teeth that are bound to be extracted. Okay, so again, in this, because now that it's COVID, we're not all very, very busy with our practices, so we have a lot of time. So these are the people who has inspired me so much, seeing their cases, how beautiful the restorations are. I mean, it has inspired me so much to improve myself in my practice. Naiinggit ako sa gawa nila, and I said, if they can do it, I can do it too. But I need to study. I need to learn more about all these steps, how this doctor does it. So you can, take a picture of this one. You can show this. And well, this is my IG account. I still haven't posted my cases yet because I'm still trying to improve myself. Okay, I want it to be perfect, but of course nobody's perfect, but I would still want to improve myself so that I can showcase my cases to the world. I mean, I guess some of you have seen my IG stories on my private account. I've shown some of my cases already, and I am proud to say that I have, with learning about biomimetic dentistry, has leveled up my practice. Initially, I was telling myself how different it is. I mean, I make good restorations too. I do beautiful restorations. I mean, my restorations has lasted me, but so what's the difference of how am I doing right now? And now that as I get myself deeper into the learning, understanding the science of how the rear restoration bonds to the tooth, it has enabled me to really, be more in depth with what I do and love what I do more to help our patients. Okay, so you in the internet, there's a lot of studies also that you can download. You can join the free webinar in the Academy of Biomimetic Dentistry, and also Dr. Lillian Ebuen has two full-day workshop. I hope someday too I will be able, if given the time. Right now I'm very busy with my practice, so given the time, I'd like to be able to create my own workshop as well, so that I may be able to share with you, to help you enhance more your practices in dentistry. So I'd like to leave with you these two verses. Okay, in the Bible, whatever you do, work heartily as for the Lord, not for man, knowing that from the Lord you will receive the inheritance, your reward. You are serving the Lord Jesus Christ. So whatever you do for your practices, do it for God. I mean, of course, we do it for our patients, but always pray and know what is really best. And let the favor of the Lord God be upon us and establish the work of our hands upon us. And yes, establish the work of our hands. So, I mean, I know still some of us are scared to go back to practices. I am a little bit, but my faith is bigger. So with this, I'd like to thank all of you and stay bonded. So if you have questions, you can email me through mitsydmd@gmail.com, or you can email me through my Instagram account. My Instagram account personal is mitsydmd. You can add me and I'll add you back. Okay, thank you so much, and I pray that everybody will be well despite all the situation. And I know to someday that this will be all over soon. Thank you. Okay, I need water. Okay, Dr. Oy, I cannot hear you. Okay, there you go.
Thank you very much, Dr. Mitzi, for giving us an in-depth explanation of the biomimetic approach. Thank you also for sharing your amazing cases with us. They're very beautiful, ma'am. So thank you so much. I'm sure we can apply. Sorry, ma'am, what did you say?
I wish I could share more. I have a lot more to share, but we don't have time.
We'll have another, hopefully we'll see you again in our future seminars. But yes, really, these are very helpful as we can apply these to our private practices as well. Thank you very much, and we really appreciate everything you've taught us for today. We would like to also thank our PPDSI working team, our partner, the UP College of Dentistry, and our sponsors, Unilab and PharmaHex, for making this webinar possible. And now, Dr. Mitzi, we have a few questions if you're ready, and after you have had a few sips of water. We just
I
have a
know.
few questions on the floor. I'm sure
I
you're
know.
also a bit parched now. So anytime
Yeah.
you're ready, Dr. Mitzi, let me know.
Okay, okay, ready.
Okay. So for our first question, Dr. Mitzi, how do you remove the color of the caries detector before sealing it? I get OC when I see color, but I don't want to disturb the affected dentine and I don't have air abrasion.
Okay, you can leave it as long as on your peripheral scene there's no more red. Okay, there's actually a studies. There is a paper indicating the color that you can actually remove. Okay, so even myself too, sometimes I get OC also, especially knowing that in my preoperative X-ray it's far from the pulp. But as my mentor would tell me, you better stop because you don't want to expose the pulp
Yes.
because you don't know. You know, sometimes you think you're still so far away and then boom, there's already the pulp. You expose the pulp already. So you can leave your caries detecting dye there. It's going to, of course, there's lesser bond to the one that is left, but the outside is the most important that you clear it all out. Your
Okay.
peripheral scene, it's important that you create a peripheral seal zone.
Yes. Okay. Thank you for answering that question, Dr. Mitzi. Now we have another one. What is your opinion using formocrosol for pulpotomy for primary molars?
Okay, I stopped using, to be honest, I stopped using formocrosol for the last 10 years. 10
Oh,
years maybe, yes. And I have very good successful result. Why? Because it smells so bad. I know it's still the gold standard, but studies right now showed that we have, you know, in the most recent paper that I saw, it was 98% success rate with formocrosol with ferric
ferric
sulfate.
sulfate.
Oh yeah,
Yes.
phlebotomy. What I do, because what number one, it's very important. You have to use rubber dam. You have to isolate it. Even the endodontists, they say that the success of your endodontic treatment will drop by 50% if you don't use rubber dam. So I use rubber dam. Let's just say you're really not used to. I disinfect it with my hydrogen peroxide on a small pellet, and then I use I have a sodium hypochlorite also. I disinfect it very well. I prepare already, and then I use my ferric sulfate. So I would say my success rate maybe 98%. I mean, I would probably uh, I can't even recall any patient coming back to me with fistula. I don't have vermocrosol. I smell so bad, especially having to deal with adult patients. I don't like my next patient that I will be smelling like, you know
Like
what how it smells.
formocrosol.
So I've had very good successful, cases using ferric sulfate.
Okay,
For
Dr.
the last
Mitzi, thank
maybe
you.
10, 12 years, I can't even
Mhm.
recall when I stopped using my formocrosol.
Okay. So we can move on to the next question. How do you remove the color of the sorry, not that. Is it necessary to use the caries detecting dye? Can't you tell with the naked eye and tactile sensation po?
No. Remember that case I showed you with the primary tooth? I thought I was already finished. No,
Mhm.
but I put on my caries detecting dye 10 times.
Wow.
But yeah, because thinking that I was already okay, I've already created my peripheral season. It was very hard. I use carbide burst. Okay, I don't use my cavity detect. I don't use excavate. I hardly use my excavator anymore. So most of the time I use my slow speed carbide. So as I was putting my caries detecting dye, I thought that I was already okay because it
Mhm.
was somehow hard already. But no, it was still turning red. So it is very, very important that you use because, no matter how good. And then also, again, there are some caries that are hiding underneath the cusp on the walls. Their cavity is
Yes.
hiding there. So when you put your caries detector, you will see it very red. It will turn red if there's still caries there.
Okay. So thank you, Dr. Mitzi. We just have a few more. So one asked, are all those cases that you presented treated under anesthesia?
I have done a lot. Well, the ones that I would need to do pulpotomy, and if I really want, yes, under sedation. But there are some that I have done. Can you believe it? Just patients crying. I'm able to do
Mm.
4 strip of crowns in 45 minutes on a rubber dam, even if the patient's crying awake. So I can still do it. Because for some of my patients, not everybody, I don't push my patients to undergo sedation. It is their discrepancy. I mean, it's the parents' decision. I don't push sedation all the time. I mean, in as much as I would, I mean, of course, I'm a mother too. I know the risk that is involved with sedation. So as much as possible, I mean, if let's say the patient is crying and moving, you know, I have a very good staff already who can,
Mhm.
you know, manipulate their movements, and I'm able to work on cases also even without having to do sedation.
Okay. How about, could you equate the use of caries detecting tint to extension for prevention principle? Would you equate the use of caries detecting tint to extension of prevention
Caries,
principle? Detecting dye, the caries detecting
I
dye.
really forgot about GB
Would
Black.
you equate it? Yeah.
Extension for prevention, no kasi parang here you remove caries. I mean, you can preserve the walls. It's not anymore, I mean, you preserve, you don't extend to prevent caries. You know, you remove up to where the caries is because you already bonded to the tooth. That's why what I like about it is that, you know, you already forget about, you know, what was taught to us, that you need retention, you need the walls to be divergent and everything. You just have to bond it. It's all about bonding. You know, even if your restoration is very flat, you can put an onlay on top of it. I've done onlays that is on a flat surface, okay, and then put an onlay. It's going to last because I did my immediate dentin sealing, and I'm confident with the bond. According to Dr. Pascal, in one of the lectures that I have dented with Dr. Pascal Mann recently with OptiBond FL, you know, it there's the bond strength can reach up to 70 megapascals, which is about 180 pounds. So
Mhm.
can you imagine if, like with Clearfield SE bond, I have about 50 megapascal of bond strength. So probably about 150 pounds to remove it, to take it out. So you only extend up to where you're seeing cavities.
Mhm. So, Dr. Mitzi, in relation to bond strength and bonding, we have a very good question here. How do you manage restoring teeth when SDF has been applied? Does SDF compromise the bond strength?
Okay, that's a very good question because I also
Yeah.
use SPF, no. But I would not. I have not done it, so I cannot really
Mm.
say. I probably would. I mean, because the caries already has been. I probably would have to remove some of the mineralized areas in SDF and create again my peripheral sealed zone. Because as long as
Okay.
there's area, because there's no studies that will prove that when you have already arrested caries using SDF, that it will, how much it's going to bond to
Yeah.
your restoration. So with that, I probably would have to remove a little bit of the SDS. Oh yes, I've done it already for anterior teeth. I removed some of the black areas. So I try to
Mhm.
clear the dentine. I create a more bondable area of my dentine. So there, but
Okay.
not having to remove everything.
Okay, so I hope that everyone took note of that because we now, especially now, we prevent having AGP. So a lot of dentists might have been using SDF right now. So yeah,
Yes,
thank you.
actually very good. I'm one of the first users of SDF, and I think I was one who
Mhm.
introduced SDF to PPDSI 20 years
Mm.
ago. Yeah, because in
Wow.
Japan we use it a lot. So now for patients who doesn't want to go back, when I see there's cavities on the adjacent areas, I use my SDF.
Okay, Doc Mitzi, what is your take also on the use of biodentine in pulpotomy cases?
Biodentin is actually also very good, but in one of the lectures that I have listened to, that there's still not much studies about it. I know that there's still more studies on MTA for pulpotomy cases more than the biodentin. Um, if let's just say ako kasi for me in my practice, if I already have pulpal exposure for primary teeth, I would do pulpotomy, the regular pulpotomy already. But let's just say if it's a young permanent teeth where you expose, you can use your biodentin as your liner, and then but then again you still need to seal that. You have to make sure that you secure that area so that you still have to secure the bonding into the dentine to secure your biodentine.
Okay, Doc. We have another question with regards to dentine. How do you deal with dark-colored aberrated dentine?
Okay, I don't remove it. Like for example, for those that have been stained already by the amalgam, as long as it doesn't turn red in my I don't take it out anymore. If my caries detecting dye doesn't turn red, I will not remove it.
Also, Doc, will the caries detecting dye only color or detect the infected dentine? Because we can leave affected dentine.
Yes. Yes.
Yeah. Mm-hmm.
Yeah, remember what I showed you. You have to have your caries endpoints. Let's say if you have a deep caries lesion. I mean, initially I was quite worried, and then when the one that I have presented earlier, I showed it to my mentor. I said, "Oh no, there's a radiolucent area," and then he told me that's perfect. I said, "Are you sure?" I've done hundreds or maybe thousands of cases like that, and then also studies have proven it already that you can actually leave your inner caries dentine. So it's okay. So that's why you have to measure it. That's why they recommend that you have to identify your caries endpoint. So let's just say that you're already in 5 millimeter from the tip of the cusp, and on the if you have class 2, you're 3 millimeter from the DEJ, then you have to stop.
Okay, Doc. So in relation to that, to your last statement, what if you're a little apprehensive with using measurements to determine the depth of caries removal? Would that mean that you're still leaving behind infected dentine?
Okay, I have I had cases like that. So that's why it is important that you take preoperative radiographs so that more or less you know. But if you are unsure, so that at least you know how far you are from the pulp. But sometimes you don't know because you're only seeing 2 dimension here. You're not seeing everywhere. I forgot to mention also that sometimes you can do CBCT. If you really want to be thorough with your diagnosis, you can do your CBCT also. But then of course I don't want, especially for young patients, I don't want to do CBCT on them. So I just use bite wing X-ray. So let's just say if you feel that you're so far from the pulp, and you can still remove it. But if you are very, very deep already, and if you don't want to expose the pulp, then you have to know when to stop. So what I do with that one, I just use, that's why I like to use the slow speed carbide, because I have control of that. I use it very, very slowly.
Okay. Doc, sorry, I hope you're still okay. We just have a few more questions.
Yes.
Okay, so here in a bonding system to minimize stress in dentine, you said we have to wait for 5 minutes if we are using the acid etch rinsing system than the bond. Do we have to wait for 5 minutes before we cure the bond?
No, you don't wait 5 minutes before you cure the bond. You can already cure it. You have to just allow for your bonding to mature into the dentine. So the 5 minutes starts counting as soon as you apply your bonding agent and as soon as you cure it. So it's either, so what I do is I cure it because I cure it, and then I start counting my 5 minutes, and then I place my my flowable composite, and then I cure, and then I place my, let's say if it's deep, I put my hybrid layer and then my fiber. So that goes together with my 5 minutes. Okay. So if let's say if your caries is not very deep, it's just very shallow, then I start to wait 5 minutes from the time that, as soon as I cure it, that's when you start waiting 5 minutes. Because you have to allow for the bond, your bonding system, you have to allow it to mature. Actually, that's why most of them, they recommend indirect restoration, because you need at least about, for your bond to fully mature, at least 24 hours. Some of even them say that 1 week, some of them they say 2 weeks. You need to allow time for it to polymerize very well, for it to bond together. You have to separate your bonding from the enamel. That's why I etched my enamel after I created my immediate dentine sleeve.
Okay, thank
especially
you.
my two-step. Now, if you're using the three-step Optibond, say Optibond FL, you can etch the enamel and the dentine together, but you have to prime. Kumbaga, you massage with using the primer. So whatever that has, the collapse of the collagen fiber will go up again with your primer, and then you can apply your bonding system. Now, for the single bond, I mean, I've used single bond. Maybe some of those cases that I have shown you, the strip of crowns, probably with the use of single bond, and it has lasted my patients too. But of course, if you want to go for the gold standard, then I would, choose either between the two of the bonding system. And
Okay.
still, also, you wait for, decouple. You have to decouple with time. You have to wait for the bond to mature. Because we all know that composite shrinks over time, right? So we always have that problem with polymerization shrinkage.
Okay, Doc. In relation to decoupling, do you always do the decoupling regardless of the behavior of your patient? Can we just use glass ionomer for speed, especially for uncooperative and young patients or patients with special needs?
Okay, to be honest with you, because my training in Japan, at that time, we were already on adhesive dentistry. So I was not really trained with GIC. I know most of the pediatric dentists, they use GIC, but honestly, I rarely use GIC. For uncooperative child, somehow I'm able, well, of course, it's very hard to decouple with time with that one, especially if you know naman that, these teeth are going to exfoliate after a certain period of time. But, I've done, bonding cases, which has not debonded, because I'm able to isolate it very well. So kahit na iyak sila, iyak, ikot ng ikot, my hand goes with them. So I have my cotton roll around it. So what is important is how you isolate it very well. So with GIC, the problem with GIC, because it's only 10 megapascals, so the strength is very weak. So I mean, if you're used to using GIC, I mean, I probably would use GIC as an interim restoration only, but not as a final restoration. To be honest, I hardly use GIC in my practice. It's mostly bonding, mostly with adhesive dentistry.
So, Doc, how do you do that with the special needs? Do you or you prefer to do it under
I still use
anesthesia or?
I still, I'm sorry.
Yeah, how do you isolate well with special needs patients also?
I use cotton roll, because sometimes it's hard to do a
Yes.
rubber dam with that one. But apparently, my staff and I are good in isolating the tooth very well. I mean, we do 400 dentistry in my practice. I can never do only, or sometimes 600. I have somebody holding the head, and then the other one is suctioning, and then the cotton roll is there, the suction is there. So even if the patient moves, okay, move around, I use that one. Sometimes I use the single bond for primary teeth, but not for
Okay.
permanent. I also have single bond, and the one of Purere, the SP, is actually very good also. So yeah, so for some of them who are quite but I don't etch anymore for children, because the etching also will make them more uncooperative.
Yes, Doc. Yes.
So
So,
the
Doc,
key is
during
really,
sorry, you were saying po. Sorry.
the key to keeping your restoration there is isolation. So I still use my adhesive, my composite.
Okay, Doc. Thank you. So, how about during this time that we have the pandemic, what are your thoughts on using SDF than GIC permanent filling? Shorter work time for us and the patient.
Yeah, I would agree with the use of SDF. At least you don't have to do it. But remember, with SDF, you have to be careful on, you cannot use it for caries that has already reached up to the pulp with pulpal exposure. You're just going to, it might turn into cellulitis later on. So that one is actually good also. Let's just say, I've had patients, that come to me and did rest on one side, but then I feel like, okay, the other adjacent teeth is not very deep in caries, and I'll just tell the parent that let's just do SDF right now. At least the caries has been arrested, and then you can do your final restoration later on. And I must admit that there are also some cases I have done in the past that that I use STF, but I only use STF for let's say for the anterior for on the lingual area because I don't like, most parents, they don't want it turning black.
Yes.
But I have done some STF in the past that I placed when they were 2 years old. That 7 years old, the STF is still there. The caries didn't progress further. I didn't need to do anything, and I just leave the STF. 1 year old, they come to me. I put STF until they're 7 years old. Time for the tooth to exfoliate. I didn't have to do anything anymore. So I love the use of STF too.
Okay, thank you, Dr. Mitzi. We're almost done. With regards to pulpal exposure, Doc, is there a measurement standard for primary teeth similar to permanent teeth where you must stop excavating?
Okay, that's a good question also. I probably would, well, of course, you have to understand that the primary teeth has, very, large pulp, okay? So that's why it is important that you take preoperative radiographs. To me, of course, there's some patients who doesn't want to take X-ray, but having a preoperative radiograph will be able to identify you. We haven't done any studies yet on how much measurement you do, but more or less you will already know it. Like for example, with that case that I showed earlier, with that particular case, I didn't measure it. So, but then somehow I'm able to see already, okay, I'm getting deep already, I have to stop.
Mm-hmm. So yes, Doc, in relation to that also, would you remove unsupported enamel when you establish the peripheral seal zone?
Okay. The good thing about, okay, so that's why it is important that you also, let's say, you have a cusp.
Okay.
The beauty of biomimetic dentistry also is that, let's say, if you have unsupported, for example, if you want to do an onlay, you can actually put composite underneath it, especially if there's sufficient. I don't open up, I don't flare it out, okay?
Mm-hmm.
So I don't remove unsupported enamel. You can actually put your composite and your fibers underneath those unsupported enamel too. So I don't remove as much as possible. We try our very best to conserve. Not unless, let's say, you have less than 2 millimeter from the base, okay? And then there's already cracks. That's why it's very important that you identify the cracks. If the cracks has already reached very deeply into the dentine, you might want to remove that and chase those cracks. But with some of the other biomimetic practitioners, they just leave it and they just put their fiber reinforced composite and then cure it. So the beauty about biomimetic dentistry is that you're very, very conservative with your tooth preparation. So it's all about bonding.
Mm-hmm. Okay, Dr. Mitzi, so after we've seen all your beautiful cases, there's actually a question on the floor. They're just curious but around how much you charge for your treatment.
Secret. That's a good question. Okay. I will admit to you, okay, because I take time now. So I have to charge more, diba? But I don't charge exorbitant. I mean, it really depends. I would probably say right now that my restoration, I with biomimetic, I probably don't go down below 5,000 because my restorations are my restorative materials are very, very expensive. The bonding system alone of SE Protect is over $200, so it's very expensive. And the time that I take, you have to value your time, you have to value your talent. So
yes, especially nowadays.
nowadays, right? And when I take post-operative X-ray, the beauty of what I love about biomimetic test, when I take post-operative X-ray, it's like, oh my gosh, it's so beautiful. There's so much steel. This restoration would last my patient for a very long time. Of course, I wouldn't know how long, but then, if with how I used to do my restorations before, that my patient lasts me probably, my composite restoration probably lasts my patient, some of them maybe 10 years. Maybe this time it might even be longer, knowing that, I have a stronger bond strength. And then when I see my post-operative bite wings, there's no leakage in my restoration. There's so much, the seal is so beautiful. So I think you have to put value in what you do. Well, one of my my colleagues in Biomimetic Dentistry charges a lot, but I'm still in the process of perfecting it. So I wouldn't, parang I feel like okay, it's getting there, but because I take time, one patient sometimes would probably take me about 2 hours to do the restoration. I know it's COVID time right now and we shouldn't be doing it. Okay, some of you might,
Yes
have a
po.
violent reaction with that one. But for some reason, I'm just so confident. But by the grace of God, I am very well protected in my practice. I come to work like as if I am facing a war zone, but I know my God is my PPE. I have that conviction of, I cannot, kumbaga, I'd rather not work if I am not able to provide good service to my patient. I'd rather not work if I will rush my case. If I will not be able to give 100% to my patient. I mean, I don't want to reopen again the restorations that I do for my patients, right? So I want to be able to make sure that I, do it well. And I am very confident that with the protocols that we do in my practice, that I use rubber dam, I have my intraoral vacuum, I have my extraoral vacuum, I have a very good purifier, I have an exhaust system, I have my window, I have my full PPE. So what else is there to, worry about? It's
Okay.
your protection. I always tell myself, okay, I will go as God leads. If God tells me stop working, then I'll stop working. But right now, I feel that there is a need for, and there's, patients need help. Okay.
Okay, everyone. Sorry, it's secret for now, but that's okay. We respect that. And thank you very much, Dr. Mitzi, for patiently answering all our questions. Thank you once again, too, for sharing your time, expertise, and knowledge with all of us tonight. Please allow us to express our sincere gratitude to you virtually by presenting the Certificate of Appreciation. So it reads, Philippine Pediatric Dental Society, Incorporated, and the University of the Philippines, Manila College of Dentistry presents the Certificate of Appreciation to Dr. Mitsyrose Navales-Antolin in grateful recognition of her participation as guest lecturer and for sharing her expertise and knowledge through the topic Pediatric Restorative Dentistry, a Biomimetic Approach, given this 31st day of August 2020 during the PPDSI String of Pearls webinar series. Signed by Dr. Paul Playa del Aguinaldo Abaya Jr., President of the PPDSI, Dr. Danilo Magtanong, Dean, the UP College of Dentistry, Dr. Romena Cornejo Castro, Awards Committee Chair of the PPDSI, Dr. Jean Arevalo, Coordinator for Continuing Education of the UP College of Dentistry, and Dr. Hazel Marie Talasunico. So again, on behalf of the PPDSI, the UP College of Dentistry, and our sponsors Unilab and PharmaHex, I'd like to thank our speaker, Dr. Mitzi Navales-Antolin, for sharing her knowledge with us and everyone who joined us tonight. It was an honor learning with you all, so thank you very much.